a formal presentation. We want to have an open forum with all of you in this discussion. So at any point, if you want to chat, feel free to use the chat box for Q&A, comments. We'll also be leaving you some information about where to send emails for follow-up questions, websites in the chat box. And also feel free to chime in at any time. Just use your hands up emoji and we'll unmute you, or you can unmute yourself and speak freely if you'd like. So my name's Katie Varnado. I'm a regional director for Catawba, Burke, and Rutherford counties. And I have a history of working in advocacy. I first started off working for the Mental Health Association in Cleveland County, and I did that for several years. And one of the things that was striking to me when I first started working in that role was previously I'd only worked in mental health. I worked inpatient in a hospital. So all day, every day, mental health, behavioral health, substance use, psychiatry, and nothing else. But when I started working in the community, I started noticing that I was working in other areas. It wasn't just behavioral health anymore. It was employment, it was transportation, it was all of these different things that come together to make whole person wellness. And I hope that this conversation that we're having today helps connect some of those dots for everybody. And I hope that you can get some good networking and some good information from this conversation. So I would like to introduce my co-panelists. I have Jeannie Patterson, who's our System of Care Community Training Coordinator, and Brandy Lineberger, who is our Population Health Program Director. So Jeannie, I'll let you go with your introduction.
Sure. Thank you, Katie. So again, my name is Jeannie Patterson, and I am one of the System of Care Community Training Coordinators here at Partners. And I have about 30 years experience in human services. Some of that has been in mental health. And I also have a variety of other experiences, including domestic violence, social services, serve work, and school social work as well. And welcome. We're glad you're here.
And Brandy, would you like to introduce yourself?
Sure. Good morning. I'm Brandy Lineberger, and I'm a registered nurse, and I'm the Population Health Program Coordinator here at Partners. My career started out as a certified nursing assistant in 1998, and I continued on and went through nursing school, and I've always had a passion for behavioral health, and that's just kind of where I landed there in geriatrics, which go hand in hand. A lot of work in Alzheimer's and dementia. And I'm happy to be a part of this today.
Thank you, Brandy. And so we're going to start off with taking a quick overview into the Healthy People 2030 plan from the state. And Jeannie Patterson is going to give us a walkthrough of that.
Sure. Thank you, Katie. So the Healthy People is an initiative that every decade the state looks at the health indicators and decides which indicators they're going to choose to follow for the next decade. And the purpose of doing this is to help be able to set targets that are going to design perhaps some of the efforts and some of the policies that are going to be implemented. Allows people to have the opportunity to work together, looks at drivers of health. And this particular, the Healthy 2030, has a total of 21 indicators that they're looking at. But again, it helps everyone to identify resources and identify where the needs are. It includes, for 2030, it also includes the digital platform that's called NC Cares 360, which again provides a lot of resources in a variety of areas. There's tools to map the drivers of health to see where there are needs in particular throughout the state of North Carolina. One of the things that's new, I think new to me, is the community health worker initiative, and that is identifying people or giving people in the community the opportunity to have training so that they can then work in a community where they have a relationship and where they're trusted in the community, and they can serve as advocates, provide information, and to help link people to resources and to services. And starting in the spring of 2021, there will be community college programs to help people be certified as community health workers. Part of this is also implementing Medicaid transformation. Some of the indicators, I won't go over all 21, but it includes things like poverty level, unemployment rate, opportunities for healthy food and for exercise, educational success, primary care workforce, which I think we all agree is something that can be improved, infant and maternal health, suicide rate, and working to address adverse childhood experiences. How can we help to reduce those to make our children from the time they're born healthier and more able to succeed? And that's a very quick overview.
And next, we're going to talk about, and let me first ask if anybody has any questions or has any familiarity or would like to make any comment about the Healthy People 2030 and how it connects back to us at a local level. No questions? Well, feel free to use the chat box, and we're going to let Brandy take over and talk a little.
Sorry, I'm going to interrupt. I just want to make sure that everybody has the option to unmute. So, Jerry, I'm going to call on you since I see your face up top. Can you just try unmuting and make sure that you have the option and everything's working correctly?
Hear me?
Yes. Okay. Well, feel free to put him on the spot with some questions later.
Jerry, you'll be our guinea pig. So Brandy, do you want to go into population health and our community assessment?
Sure, but we do have a question in the chat box that I see. It says, where can we find more information and literature on Healthy People 2030? So if I'm not mistaken, I believe Jeannie can probably drop a link into the chat box. Thank you, Jeannie. So again, I'm Brandy Lineberger, and I'm going to briefly talk about population health and community health assessments. And so the first thing I want to do is talk about the importance of utilizing Healthy People 2030 as a guide. So in population health, we use that as a guide to help decide the initiatives and the things that we're going to try to work on to improve the health of our communities and to improve the outcomes of our members. And so we looked at those things that Jeannie just talked about. So we look at poverty, we look at the workforce, we look at some of the things that Katie discussed, like food access, where are food deserts. So those are all types of things that we look at. We also look at health items. So we look at things like diabetes, hypertension, obesity. We look at, COPD, asthma. So it's basically, when you think about population health, it's everything you could possibly think of that could affect anyone in any way. So it covers a very broad range, and it's a lot of different things to look at. As far as community health assessments, so basically every county does a community health assessment. And in that community health assessment, they'll identify usually 2 to 3 things in their community that are very prominent and very important to them and things that they want to improve upon. And so a lot of our counties have identified things such as transportation or possibly food, access to food. We've seen workforce development needs. So we've seen a lot of different things depending on the county, and each county is very different and they have their own needs. And so that's the really neat thing about a community health assessment. It allows them to utilize community input. So a lot of times they send out a survey or multiple surveys into the community, and that allows the people in the community to give their opinion and voice their concerns. And then one of the things that happens is they compare the identified needs with the past health outcomes. So things that are identified, they will look and see where they've been, where they've come, and where they hope to go. So you're looking at past, present, and future when you look at a community health assessment. And you want to plan for the future needs of that community and try to help that community to become a better community and have the best outcomes possible for the folks that live in those areas. As far as SDOH, so that is social determinant of health assessment relationship, here at Partners, in the Population Health Department and Care Management and Member Engagement, pretty much almost all of our departments, we in some way encourage social determinant of health assessments. And so what we want to do is to identify needs for work, food, safety, insurance, and housing. And one of the latest things that I've actually been researching personally is also technology, because it dawned on me the other day that we have folks that can't access technology. And so that's one of the things I want my team to be looking at future state is, how can we try to encourage folks to be able to get access to technology. And so that's just one of the things that we're just now barely starting on. Like we just started the conversation yesterday. So y'all are getting pretty much brand new information from me. So that's pretty exciting. So we want to look at those things, and we do these surveys. We have our providers do the surveys in our communities with the members they work with. And as a part of that, we try to identify what the most prominent needs are in each county. And then we compare that to the community health assessment to try to see what types of initiatives we need to try to put in place. So that's, to me, a very neat thing that we can do in population health. Another thing that we do in population health is health risk stratification. So we look to see all the things that affect and influence somebody's health. And so we try to look at that on a population level. So we look at the entire population and we say to ourselves, what are the things that are going to affect these individuals? And so we want to know, is it going to be diabetes, hypertension, obesity? Is it going to be their mental health? Obviously. Is it going to be work? All of those things lumped into one. And then we want to look at health promotion. So we want to try to encourage healthy living, activity, mental, emotional, and social well-being. And those are all things that Jeannie and Katie both talked about just a moment ago, as far as when you're looking at Healthy People 2030, those are all on there. Those are all things that we hope to be able to guide to improve in our communities by promoting those healthy activities, getting people more active, getting them out and about and just doing that healthy living and trying to improve as much as they possibly can. And then another thing we want to do is health prevention. So we want to promote in the community and try to prevent some of the folks from, or as many as we possibly can, from developing diabetes, hypertension, obesity, coronary artery disease, all of those types of things. We want to try to prevent that as much as possible. So how can we do that? By promoting healthy foods, by promoting healthy activities, and also by promoting healthy living in general. And so those are some of the things we try to do. And then interventions to improve or reduce the health risk within itself. Those are things we like to do with our members as well. We want to try to help our members have the best possible quality of life that they can. And by doing those things, that's exactly what we try to go, aim for. That's our goal. And then the other thing we want to do is we want to improve outcomes in our communities. So we want to improve the total outcome. So when you look at a community, you want to have a goal and you want to try to put things in place to help achieve that goal. And so all of those things together sort of make up population health. And so I think I have one of the neatest positions here at Partners, in that I get to look at the entire population and try to figure out how can I help our entire community. So to me, that's a really neat thing that I get to do. So with that overview, are there any questions about population health? Does anybody have any discussion around that?
Brandy, I have a question.
Okay.
Have you noticed across our catchment area any specific trends in population health?
We have noticed some trends. So some of the things that we've noticed is around obesity, hypertension, diabetes. We've also noticed some things surrounding workforce development. So when we look at that, that's also a big indicator. So those are things that we've all noticed varying trends with, and we're trying to plot and try to figure out, now what interventions are we going to put in place to try to improve those things. And, we can't overlook COVID-19 either. That's had a huge impact on us, unfortunately. So, that's made things quite complicated. The access to primary care physicians right now is pretty limited because, for the past year, we've had individuals that have not been able to access primary care for a face-to-face visit. And, we possibly have folks that have not had their blood pressure taken in quite some time or haven't been weighed. So I'm sure we will see some trends that come from that when we're finally able to get back in there and get those well checks and get those primary care prevention appointments, done. So that'll be interesting to see what that is. I know we've all heard about like the COVID-15 where we've, unfortunately, a lot of us have gained some weight through COVID because we're not as mobile and we're not as active and perhaps not making the best food choices as we're all at home. So, just trying to get out there and be more active and encourage our members to be, more outside if they can, take walks and do the things that they can that will help to benefit them and their families.
And I think looking over our guest list, we have a lot of our people here with us today that are with nonprofit agencies and organizations. And I wonder, do you mind speaking a little bit to how the Healthy People Plan and the community health assessments can kind of bolster grant writing?
Absolutely. So that's a great point, Katie. That's a great way to pull those things together. So if you're, a nonprofit agency and you're seeking out a grant, you can use the Healthy People 2030 as a part of the goals that you plan to obtain. And so I'll just use, let's see, let me think of one. I'll use a food bank, for example. So if you are a ministry that has a food bank and you're seeking out to write a grant to try to obtain funding for healthy foods, so you could absolutely use Healthy People 2030 and use some of those goals in there to put inside of your document that you're writing to try to help encourage the award of that money to your agency. So that's definitely a place that you could do that. Another area right now is workforce development. So if you're a crisis ministry or a community-based organization that is a nonprofit and you're trying to do some type of grant writing to get help with getting people placed in jobs, maybe you have clothing that you can provide or something like that, and you need, funding to try to get that to the community. That will be a great way to do it too. So you could pull stuff from that community health assessment saying, hey, this county in specific has a need for workforce development. We have these folks that are looking to obtain positions in competitive employment. And so this is our goal and this is what we want to do. And so you could pull that information specifically from the community health assessment. And then here at Partners, another thing we can do when we're seeking out grants is we can use our social determinant of health information. And so we can actually identify areas of need and help to put that into some of the grants, especially like the SAMHSA grants that we write and things like that. Anybody else have anything?
Well, I think population health is fascinating, so I can keep on asking you question after question. So.
Well, keep going. It's great. I love talking about it. I love population health.
One of the things that we've talked about and that you mentioned is the social determinants of health surveys. Mm-hmm. Do you want to dive into that a little bit?
Sure. So I love the social determinant of health surveys that we actually do. So a lot of our providers do those with the members that come in. They'll do them at their regular appointments. They will also do them on intake, and then they do them many times every 3 months. Now, with that being said, we do have some providers who do those assessments every time a member comes in. It's totally up to the agency as to how they want to do that and what frequency they wish to do that. So one of the really neat things about the assessment is not only does it look for things that are a current issue, it also looks for things that have been an issue in the past 12 months. And I love that because, you know, a lot of times you might have had an issue that was in the past 12 months. Now it's fixed, but we as, you know, caregivers, you know, as a provider agency, when you're looking at a provider agency, if you're looking at a clinician, they need to know this was a past need for this person, and they need to have that kind of on the radar, so to speak, to know that this could pop up again. And so one of the things that it looks at is housing. So, you know, housing right now has been a huge issue in all of our catchment. Pretty much with COVID, we've had a lot of issues. And so when you look at that, you know, you want to know that that was something that was an issue for this person, this individual you're serving. And so you want to make sure that you keep them connected and that you try to see things before they happen. And so a lot of times by doing that assessment, they're going to open up to you and let you know, well, I have housing right now at the moment, but, you know, I don't know that I'm going to be able to pay my rent next month. So bam, it's on the radar. So you need to say, okay, how can I start getting into action to help this person? And so another thing that it looks at is safety. And so safety is an automatic, what we call trigger. So if they identify a current safety need, that's what one that we have bolded. And so that's an automatic need for a plan. So something needs to be done then at that appointment to try to help that person to obtain safety. And so I love that too, because it gives that person an opportunity to express that they have an issue or a need with safety when they're in an appointment, and not necessarily, you know, having to call somebody or, you know, speak it verbally in front of someone who could be the person that is causing harm. So that gives them the opportunity to kind of step outside of that box and discuss it in a different way. Another thing it does is it looks at food. And so, you know, North Carolina Care 360 is going to be an awesome tool for us. It's going to be awesome for our providers to be able to connect people. It's going to be awesome for care management, because one of the awesome things about it is it closes the loop. So we'll know what happens. We'll know, was that link or referral successful? Did it actually work? Because how many times do we wonder, okay, I made this linkage, I made this referral, but did they get food? And so it gives the opportunity for that community-based organization to follow up and let that care manager know the linkage was made, the referral was accepted, and we were able to provide XYZ. Or our agency doesn't have that right now, because y'all know food is an issue right now, and we've had a lot of issue with obtaining it. So let's just say a care manager did a referral to a food bank and they're just low. They don't have enough food right now. So that food bank could actually follow up through North Carolina Care 360 and say, I apologize, but our food bank doesn't have that food available right now, but we do know that XYZ down the street does have that available. And so then you have that secondary referral that can happen. And so that's I think that's a great part about North Carolina Care 360 too, is closing that loop and making sure, because there's so many times that we're so worried as clinicians and nurses and providers. People worry, you know, did that person, that member get the help they needed? And so that gives us that opportunity to make sure that those needs are truly met. So I hope I answered or elaborated on what you were asking for, Katie.
Yes, absolutely. And have you noticed any SDOH trends, since we've been collecting that data for several years now? So have you been able to notice any trends with, you know, what are the biggest needs regarding SDOH?
And so social determinant of health needs are very different depending on the area. So in some of our northern areas, you'll see transportation is more of an issue. So your Surrey, Yadkin areas. In some of our other areas, you'll see that, you know, work workforce development or work is a need. And so one of the really neat things that I like about the SDOH assessment is when some people are identified as eligible, they can actually be linked to individual placement services and supported employment so that they can try to obtain employment, competitive employment. And so that's a really neat thing about it too. So, you know, by identifying those needs in the different areas too, on the flip side in population health, we can try to make sure that we're trying to bolster or plump up the services in that area. So we can try to, like you said, Katie, use it to write, you know, try to help get grants or try to put programs into place or get resources going, you know, and a lot of times there are resources there. It's just that the need wasn't known, right? So what we want to do is identify the need in the area, find the resource in the area, connect the two and make it work. And that can happen. And we've seen it happen. Jeff Eads and I, you know, we've worked a lot to try to identify areas of need in different areas. And then, you know, some of the other regional directors too, we've, you know, worked together to try to identify exactly what's going on in this area of our catchment and how can we try to get these resources plumped up to make things happen. And so that's really neat.
So we're having, it allows us to have community specific interventions. So it's like person centered, but community centered.
It is. And so that's, you know, that's super neat. And I love that we're able to do this now because as I look at it, you know, over the time that I've been at Partners, I've been here since 2012. And previously I was on the geriatric team. So a lot of needs come up in the geriatric team. And now I'm looking back and I'm like, wow, you know, if we would have had these resources then, as far as like the assessments, we could have done like so much. Now, granted, you can't get down because a lot of times I'm like, oh man, I could have helped so much more. But what I do is I put that to practice now. And I'm like, okay, what can we do to move this forward? So you can't stay in the hindsight, you got to go forward. And so that's pretty neat for me to be able to see how far we've come from 2012 to now. And we really have come a long way.
I think so too. And I think having that data allows us to be able to see the needle moving and demonstrate those outcomes. So I think it's really neat too. So my next question is for Jeannie. Brandy mentioned a little bit about ACEs and trauma, and Jeannie, you and I have done some work around CRIM training and stuff like that, and you're way more involved in it than I am now. But I wanted to get your opinion and your insight into how ACEs and trauma affects population health.
Oh my goodness, it affects it so many ways. We know particularly, well, we know that when children are exposed to trauma, that it changes the structures of their brains. And so it affects, first of all, it affects education because of the parts of the brain that include memory and also judgment. Those kinds of things are directly impacted whenever a child experiences trauma. But also we know now because of the ACEs study, which goes back now to the sort of mid to late 90s, that there is a direct dose specific connection to the number of ACEs, that the number of adverse childhood experiences someone has, to long-term health deficits. And if you don't, let me back up just a moment. When we talk about it, you probably all know ACEs, but just in case, it currently has 10 different criteria. And if something happened to you, if you witnessed something, one of these 10 criteria, on a more, not just a one-time isolated incident, but before you turned 18, that counts as 1 point of your ACE score. So it includes things like abuse, of course, sexual, emotional and physical abuse, also neglect, emotional and physical neglect, and then household dysfunction things. For example, a caregiver who abuses substances, separation or divorce of the caregivers, incarcerated caregiver, hunger, those kinds of things. So you can technically, because of that, you can have a score of anywhere from 0 to 10 of your ACE score. And starting at about 4 on the ACE scale, there is a direct connection to long-term health deficits, including course, it includes things like mental health, substance use, but also things like cancer and diabetes and those kinds of things. And what we know now, and of course, we're still learning, but what we know is that things like, for example, inflammation, all those stress hormones that flood through our body does cause an increase in inflammation, and many of those things, those conditions are impacted by inflammation. Also, some of the things, for example, when we talk about healthy eating, cortisol in our evolution was one of the things that cortisol does is cause us to crave sweets and fats. And again, think about it like carb loading for cavemen. So it served a valuable purpose in our evolution if we were needed to be able to hunt for a large animal for food or to fight people in the neighboring village or whatever. We don't need that so much now. But what happens, and I've partly from my school social work experience, I've worked with families who lived in really high poverty areas and trying to encourage them to do healthy eating and community gardens and those kinds of things. And it was really difficult, even if they wanted to do that, it was really difficult to keep that habit. And probably many of us have that as well. And it's because of what cortisol does in our body, as those hormones are being flooded through our bodies, that it's causing us to crave those things that are less healthy as we're eating. So I love talking about ACEs.
No, I actually want to kind of dovetail off what you said, Jeannie, because of the physical health side of it. So cortisol within itself, that when you have a high level of cortisol, it can actually cause your body to produce those inflammatory reactions. And so what we know is, you can have vascular changes. So that can lead to some of the coronary artery issues and heart disease issues, as well. And so that's definitely, a great point that you point out there. And then the other thing I wanted to point out was, through the community resiliency model training that we did, the CRIM training, you'll hear people call it CRIM. So if you have not had CRIM training, I highly encourage you to have CRIM training because it made a difference for me and my family. And Jeannie, I don't know if you remember, but I was able to use CRIM skills like the very Monday after we had the training. We had a neighbor whose house burnt down. And so what happened for that person was they really did, their body physiologically did not know the difference in, like serious trauma. So, your body, even if it's a minor trauma, your body can see it as a very serious life-threatening trauma. And so that situation could have been life-threatening for them. They weren't at home when it happened, but they came home to see it happening. So their body perceived it as life-threatening. And so I was able to use some of those skills to help stabilize their nervous system and get get everything back in check and kind of calm them down. So yeah, if you have not had the CRIM training, I strongly encourage you to reach out. And I believe they would reach out to you, Jeannie. Is that correct?
Yes, in fact, I have been offering it and will continue to offer for the foreseeable future a virtual version of CRIM once a month. It's free and anyone can participate. It's about, the one we do virtually is about 2 hours. So we aren't going into a lot of detail, but we do offer learning about the skills and learning how we can use them. And I've had people, I actually had a participant one time texting me or chatting, talking about how she was, there was an issue with her child being schooled at home, and she was actually messaging her husband saying, try this with her while we were training. So the skills are very natural and easy to learn. And if you look on Partners calendar, or I'll look before we get off and tell you the date of the next one for May. But yeah, we're very happy to do that. While I'm open, let me just mention, in case anybody else has any thoughts about this, not to change the subject, but in the chat, there's a question about helping financial assistance to help people who are living in poverty, who may want to move, and also to be able to access healthier food. We know, unfortunately, that we live in a place or a time in our culture that it's cheaper to get something fast food sometimes than to get healthy fruits and vegetables and those kinds of things. So does anybody want to address that? It may be something that we need to research and get back to the group on. Anybody have any thoughts about that?
Well, I can speak a little bit to it. So I know there are some resources online through FNAP. And so, and I can put that in the chat after I finish talking about it. But FNAP, it actually gives people the access or the ability to print grocery type lists. And it's for healthy foods and healthy eating. And so it actually gives them advice on how to use their SNAP benefits to better get, I guess, more bang for their buck. So it kind of stretches that and helps them to be able to create and use these healthy recipes with their family. So that's one way that we could do it for sure. So I'll be happy to put that link in the chat. But I would love to hear if anybody else has any suggestions. That would be great.
And Jamie Piercy, I don't mean to put you on the spot, but we do have a list of help and resources, right, that we might be able to send out.
So I don't know. But what we're trying to do, Katie, is we're trying to really get away from lists because things change so frequently. So we've really been using more Aunt Bertha for resources for each county and community that we serve. So we've been pointing everybody in that direction versus coming up with a formalized list, but especially since, you know, COVID and things are changing so frequently.
Also, one other, in addition to Aunt Bertha, people can call our, all right, lost mine, can call, I'll put this number in the chat. It's the number for the member engagement, and they can get more information as well from that. Specific about for people.
And I want to throw another comment too that I just thought of. Community gardens are a great option too. So, you know, a lot of times it would be a really great opportunity to write for a grant if you're a community-based organization or agency that's nonprofit. I know like Lowe's, Home Improvements and Home Depot and things like that will oftentimes donate plants or seeds to help start that community garden. So you could possibly write for a grant to try to get some assistance with that. That would be a great opportunity. I know a lot of the county food councils are doing that as well. So just researching and finding out what's going on as far as resources in the community for community gardens. That would be a great thing to do.
And we have a question from Diane Patterson. Are there any resources for getting assistance to help members apply for SSI, SSDI through the SOAR program? And I can speak a little bit to that. It really depends on what county the person is living in, because not all counties have SOAR, and the counties that do, it's various providers. So we may need to reach back out to you, Diane, and get a little bit more information on that. But in the counties that I serve, 2 of them have a SOAR program, 1 of them doesn't. So it just depends on what county you're in and how we can get you connected that way.
Also in the chat, there's a comment which really points out when you think about how interconnected all of these issues are, because we know one of the things that affects food access is transportation to get to grocery stores. And, you know, to sell, I heard somebody one time made a comment, well, they could just walk. And if you haven't carried 10 grocery bags for a mile, that might be prohibitive to being able to do that.
That's really true, Jeannie. And I saw Jerry put in here that they literally shop for groceries at the dollar store. That is absolutely true. I've seen that quite frequently, and you know, it's not the healthiest foods that are available there. I do know some communities have tried to work with their local convenience stores, especially through the farmers market, to try to offer some fruits and vegetables at those little convenience stores, so they are within a closer distance, like you were talking about, Jeannie. So they'll be able to go to those local close by convenience stores and buy things like bananas and apples and tomatoes and things like that. And I don't know if any of you have ever bought, you know, anything like that from your convenience store, but sometimes the farmers bring those things in, and I can tell you what, some of those cucumbers and tomatoes are the best in the world that you can get from the little local convenience store, because the farmers brought them in and they're pretty good. So give it a try, because, you know, unfortunately, if we don't use the resources, a lot of times they'll stop. So we need to make sure that, you know, we encourage people to buy those things when they're, you know, financially possible at those local convenience stores, so that those farmers, they continue to bring in those products and have them available for the folks that don't have that transportation.
Someone in the chat has also pointed out something that for many of us probably have used, and that is the ability to get groceries delivered, particularly now, and particularly for seniors, how that there's more opportunity for online ordering and grocery delivering.
That's true. And that's a really great point too, Jeannie. And thank you for putting that in the chat. So one of the things that does concern me, though, that I was thinking about yesterday is, again, and you were talking, Jeannie, about the interconnectedness and that how it all fits together. So there we have the technology issue. So I thought, you know, if this is available, that's great, you know, and if it's available in their area, that's wonderful. But what if they don't have the technology, or they don't have the computer access or internet access or smartphone to be able to place those orders? So it's all definitely connected, and you know, it's, you know, something that we're going to have to work on collectively. You can't just pinpoint one thing. You've really got to pull the whole load together.
And to kind of circle back to the Dollar General comment, my colleague Jeff, and I'm sure Andrew, I saw Andrew on here too. We have sat through a lot of, we attend our county commissioner meetings, and we hear a lot about the Dollar Generals in each of our counties. And one really interesting thing that I heard recently was that the Dollar Generals were partnering with pharmacies to help do vaccine clinics. So I think as part of our collective impact model, I think it's an opportunity to explore those partnerships rather than, you know, I think that the Dollar General, this is just my opinion, has gotten kind of a bad rap in a lot of areas, but really there's a big possibility and opportunity to connect those dots through our collective impact model, and to really utilize the Dollar Generals, especially in the food deserts, to get people the fresh food that they need, or even in this case, vaccines or medicine. So I think it's a real opportunity and a different way of looking at it. I don't know if you have any thoughts on that, Jeff.
A lot, many thoughts, you know, that are it's such a rich conversation that you all are having today. And, you know, obviously, because we serve a lot of rural communities, counties that have even more rural communities within those counties. Yeah, a lot of those convenience type stores have filled a void, if you will. And because their cost model is such that they can afford to go into those areas where another maybe major store would not have the volume to be able to, you know, serve those communities, they have. So I think, like you said, Katie, rather than look at it as a bad thing, it's like, how can we capitalize on it and work with what we have? Because in some communities, you're exactly right. That's the only available option, and no one else was showing up to again fill that vacuum in that space. But this is all part of that bigger conversation that you, Brandy, and Jeannie have opened up around population health. It's so much more complicated, isn't it? It's not just eat better. It's not just get more primary care. It's not just accessing transportation options. You have to go so much deeper to say, and start asking those why questions and really defining the problem. Because I think what we do a lot of times is we come up with a lot of solutions that we want to throw at things, but we're not getting to the core item. And like Brandy was talking about, getting to a point where we can actually measure and determine which of the interventions that we're doing make a difference. Otherwise, our scatter shotgun approach is we're just left with wondering what worked, what did not work. So yeah, I think you all are hitting on it. It's like folks are struggling with food health. Why? Because there's not access to healthy vegetables. Why? And just keep going until we get to the bottom of it. So it's challenging work. And I think we're at the beginning of it. It's really the genesis where people have started to really put the pieces together to say, it's not a transportation issue. It's not a food issue. It's a collision of all of these issues, creating more of a syndrome than a singular type thing. So I think you all are hitting on some really good points today, Katie, which is to look deeper. And like you said, Katie, not necessarily, and to remove the robe of judgment to say, oh, this is a bad store or this, but to just say, okay, this is what we're working with. What are the steps we can do to improve upon that? And how can we educate people about their options? Because that's the other thing. When Brandy was mentioning something like printing off recipes, then we have to ask the question like, okay, now I have printed off the recipe. Can I get those items?
That's right.
Have access to those items? And if the answer is no, how can we at Partners help manage that process so that the person's barriers can be removed to get to that next place? Sometimes the very act of creating a grocery list, coordinating, getting to the grocery store, purchasing those items, preparing that as stated, think about all the steps that are involved in there and how many healthy things that have to be in place for something. Again, the most simple things, I say this often, the most simple on the surface things are often the most complex because we take them for granted at times. So yeah, Katie, you can tell I have a lot of thoughts about it. I'm pretty passionate about it too, because I think what you all are opening up today is really, especially as we're talking about Partners and our move toward Medicaid Direct and then ultimately to the tailored plan, because we will be working with folks who have more severe and chronic needs, behavioral health, and I include mental health, substance use, abuse, as well as intellectual and or developmental disabilities in that, to help them, again, get the things in place to improve their overall health, well-being, quality of life, and access to the things they need to live a full and productive life. So thank you for asking. And thank you all for wonderful information so far. I mean, I've been doing this for a while and I feel like I'm still learning about resources and things. So to Jamie Piercy's point, creating a list, so she was bringing up the NC Care 360, Aunt Bertha, some of those other resources, which I hope folks know that are available. Those are updated real time. And again, those are those tracking mechanisms so we can know did something, because it closes that loop, as you all were saying. Whereas our paper lists are good for only from the time we print them back to wherever you're going to distribute them, then they're obsolete, aren't they? So great resources. So thank you, Katie.
No, thank you. And I think you make a very valid point about as we're moving into Medicaid transformation and working towards a tailored plan, that we, part of that plan is to look at whole person wellness and the social drivers. And I think circling back to Jeannie and ACEs and trauma, that's a way for us to scientifically connect physical health with behavioral health, and just piecing all of those things together, and then cross-referencing it back to our state priorities. So it connects back on the bigger picture where we have the data, the state data, and we have our local data to support our priorities. But then we have the social driver of health data also to make it really personal and individualized for the person that we're trying to serve. So I hope that we are creating and we have created this continuum of serving individuals, families, and communities based on what those needs are.
And Katie, if I might add one more point, I mentioned rural areas, and I don't want to leave my comments with people maybe interpreting that as this is only a rural area problem. It is not. In any type of urbane or urban area or heavily populated area, same things, same pockets, because there's communities within communities within communities. And you can see those things in a heavily populated city where people are living in a food desert or without access to those things just as much as you could in a very rural and remote area. So I just wanted to make that clarification that these same principles that you are talking about, all of you, are applicable no matter the size and population density of a community. They do crosswalk these interventions into all of those areas. Because I really think what you all are trying to say is get to know your community, know the residents, and then not to make a blanket statement about what health and access to healthcare looks like in those communities. It has to be very, very, very much down to that specific community, and then down to make that person centered within that specific community to really push that change. So I just wanted to make sure I was clear on that. So thank you, Katie.
I think that's a good point too, Jeff. And so I think about like that because a lot of us went through what we call the A3 process. And I don't know if people have heard about the 5 whys, but that's what we have to do, especially in population health, is you like act like you're a first grader and you're asking that why, and then the why, and the why, and you continue asking why until you get to the very bottom of it. And so that's what we have to do, is we have to continue asking those whys. You know, we might think one thing is the issue, but when we really truly dig down and get down to the bottom of it, it's really not. And so I heard a doctor say one time, and this was a quote, and it was actually in a social determinant of health training that I attended a couple of years ago. And he said that all these years he had been treating stomach pain when hunger was the actual problem. And so I'm sure a lot of y'all have heard that, but that kind of sticks with me. And I kind of think of that daily as I serve and as I work to try to improve access for our members in our catchment area and the communities. I want to make sure that I am looking at the real issue and not just, you know, touching the first one that comes up.
Thank you, Brandy. And I want to make everyone aware also that Partners has a no wrong door policy. So if anyone on this call or Zoom needs any resources, I put my email in the chat box. You can reach out to any one of us at Partners, and it's our open door policy. We can connect you with the right person if we don't have the answer, and connect you with resources. So we want everybody to be able to find the resources that they need when they need it, whether it's through Aunt Bertha, NC Care 360, through our Partners Hope Line, or through us individually. We'll be glad to help connect anybody with resources.
I also just want to point out that the link for Aunt Bertha's in the chat as well.
And would anybody else like to discuss anything or have any questions for Brandy, myself, Jeannie, or anybody on the call? And Jeff is going to give us a little bit of an overview of our community cafe for next month, which I'm really excited about.
Thank you, Katie. And our next community cafe will be on May 26th, same time, same channel. You can use that same registration link that you used to get to this one to register for the one in May. But myself and Jerry Campbell will be facilitating a conversation, much like today. We want it to be very much, again, a cafe where we're talking with one another. And the topic that we're going to be covering is community collaboration and coalition building. And it's really going to be an introduction so that folks that are participating in our next community cafe will have the opportunity to hear from people who are very much involved in that type of thing in their local communities. And just to give you a teaser on it, we'll have Mr. Mark Willis from Surrey County, he's the director of their opioid response and recovery initiatives in the county. We'll have Ms. Jessica Wall, who is with Yadkin Human Services, and she's the Assistant Director for Public Health. So she's over the public health side. And Mr. Brett Eckerman, who is the Director of the United Way of Iredell County. So 3 people that Jerry and I have worked closely with on successful coalitions, as well as collaborations. But Jerry and I did want the group to know that this is not Northern region oriented. It just so happens that Jerry and I work in Surrey, Yadkin, and Iredell. So those are our stomping grounds in the region we cover. But this is for the whole catchment area. And what we hope that this will do is it will start to create a network or get folks linked in with others who are going about the business of collaboration and coalition building, so they can have some friends and some experts in that as they start to look at solutions in their communities and how to do that. So we think it'll be informative. We think it'll also be with the people that will be involved. We think it will also be entertaining. So there will be some value there as well. And we hope it will be motivating and energizing and give people some of the tools to go ahead and get started with that process. So thank you, Katie. And we look forward to seeing folks on May 26th.
And also, I want to put in a plug for our community health assessment work groups. Each county's health department does the community health assessment usually biannually, and they recruit community members to help serve on that board and pick the health priorities. And I know a lot of you on the call, I serve on some of those boards with. So you get to see the value in it for our communities. But if you're interested in joining some of those work groups, you can reach out to your local health departments or us at Partners, and we can help get you connected also.
Just there's information about the community health assessments and also the link for the registration for the next community cafe in the chat.
And if there are no other questions, I want to say thank you all so much for coming and being a part of this conversation. And we hope this is our second one, and we hope to keep building on it and have really rich conversation that is useful to you and full of resources. And hopefully you all come away with something that you didn't have before you joined us. So I appreciate you all being here.
Yes. Thank you, everyone.
Thank you, and we'll see you next month.
Thanks.